welcome to Open Mind Night, a show that talks about everything mental health and mental illness related. I'm your host, Robin Tamanaha, licensed marriage and family therapist. Joining me on this episode is my guest, Dr. Martin Cha. He is a psychologist, trainer, and lecturer specializing in empowering people with OCD, anxiety disorders, and insomnia to reclaim their lives. He supervises therapists and psychiatry residents in providing cognitive behavioral therapy skills and interventions, and is the clinical director of CBT SoCal, the CBT Center of Southern California. Hi, Martin.
Robin, thanks for having me.
Yeah, thanks for doing this. How are you?
Good. Yeah, I know we've spoken just a couple times before, so just happy to provide any information that's helpful for the audience here.
Yeah, definitely. Thanks for doing this. I have a lot of questions, specifically related to your bio here. And so maybe we'll just go through, some of them, just to give the listeners and then those watching, some information, especially when it comes to OCD. I feel like there might be some misconceptions or even some people who may not even know the difference between, let's say, like OCD and like anxiety. Could you maybe first kind of talk about maybe the differences between those two?
Yeah, sure. It's a great question. And you'll see a lot of people who maybe say that they specialize in OCD and anxiety because, yeah, there are a little similarities. But I think one way that's helpful to kind of categorize these sort of labels or things that we have is that, in the past, in our DSM and how mental health issues were, literally categorized and diagnosed, OCD was a specific diagnosis under anxiety disorders. So the larger umbrella of anxiety disorders included, post-traumatic stress, PTSD, OCD, then there's generalized anxiety disorder, panic disorder, social anxiety disorder, then there's, specific phobias, things like that. And in the more recent iteration of the DSM-5, OCD was sort of kind of taken out from under the anxiety disorder category and given its own category, if you will. That doesn't mean that there aren't still overlaps with a lot of other anxiety disorders. And we see people that may have OCD in some form or fashion, as well as panic episodes. They may have a trauma history. They may have social anxiety. They may have, health and illness anxiety, which is pretty much OCD just dressed up a certain way. So, but there are specific things that we identify as OCD when there's like ruminating thoughts or compulsive behaviors that are designed to reduce the distress caused by an intrusive, unwanted obsession. And there's different forms that OCD can take, and a lot of times it's not always clear. Is it kind of like a broader generalized anxiety disorder, or is it specifically OCD? It's not always really that cut and dry in real life. So,
got it. Mm-hmm. That makes sense. Thanks for explaining that. And I think it's really interesting as you mentioned, like the newest DSM with the DSM-5, how it became its own. Became its own category with it, which I think makes sense because it's like complex, right? And I know there's so many different types, even like subtypes, even when it comes to OCD. I kind of even wonder if there's people who may be living with OCD but may not know about it. Because I think some people may have like certain ideas of maybe what like OCD may look like. I think the thing I always think of, I don't know if you've seen that movie, like As Good as It Gets, where sure. That's I think what people think of usually, but that's not always what it looks like, right?
For sure. Yeah. I think you're right. I mean, I think probably the average person walking around out there, has heard about contamination fears and people who wash their hands very excessively, or maybe people who like check their lock, multiple times, or their stove. Like these are sort of more commonly known forms of OCD. And then there's sort of the, sometimes unfortunately colloquialized use of OCD as an adjective, like, oh, my, so-and-so is so OCD about their appearance, their hair, their clothes. And it's sort of thrown around a little bit flippantly just to express someone who takes something very seriously or is very organized or something. But that doesn't quite capture the distress, the genuine distress and debilitating effects it can have on someone's life who's really locked in a cycle of like, no, I feel like if I don't, wash my hands 7 times or repeat something in my head in a very prescribed ritualistic way, or walk 3 steps forward, 3 steps back, then 4, or something like in a very specific and sometimes otherwise arbitrary way. If I don't do that, really in my mind, something terrible could happen. And even if part of me knows that that doesn't make sense or that doesn't seem rational, I just can't tolerate the possibility that that could happen. OCD wants 100% certainty for what we want or what we don't want to happen. And the reality is we live with, some uncertainty every day. And those of us who aren't suffering actively with OCD sort of take that for granted or just can tolerate that most of the time. But people with OCD sort of wear down the mental and emotional ability to do that in certain contexts.
Yeah. So, and it almost sounds like, too, as you described this, what came to mind was like, if I think this, like if I have this thought, it's going to happen. So then they're like doing these different things, these like reassurance things. Is that kind of correct?
Yeah.
Yeah.
Absolutely. Yeah. Right. So a really common thing with, one form of OCD that may be less known about is sort of, postpartum or perinatal OCD, where, someone who's just given birth, a woman who's just given birth, they're mother and has this precious baby that they love, and just has a random thought, or someone mentioned something about a baby being hurt and just thought, what if I did that? What if I dropped my baby or drowned my baby? And like, oh my gosh, that's such a terrible thing. Why would I even think that? And wait a minute, am I thinking that because I'm actually dangerous or I'm capable of doing that? And I'm in denial that I might actually want to do that. Maybe I'm actually a dangerous person. And so just to be safe, I better, check with my spouse over and over, like, I've never done anything violent, right? Or ask my parents, like, did I ever, as a kid, did I ever have any trauma? Or maybe just never be left alone with my baby, even though I need to be nursing, right? So it just leads to a lot of reassurance seeking, as you said, sometimes, or just avoidance or sort of ritual, some ways to, in the short term, alleviate the stress of the uncertainty that thought could be true. But again, someone without OCD might say, I had a weird thought, and wow, that's a disturbing thought or a random thought, but I don't place any extra meaning on it as possibly true. So I just kind of move on with it, So that's the real difference.
It sounds like a kind of this cycle, right? Where you have this like thought, right? And this concern, and then whatever the reassurance is, or like maybe the action or compulsive behavior, and then it kind of maybe, like you said, alleviates it for short term, but then kind of goes back because it doesn't get rid of it. And so then is that how it kind of happens, where then it just turns into this cycle and this
100%. I mean, if you think about it similarly to how an addiction can grow, right? Like, let's say I have a drinking problem and I'm dealing with the stress. Well, hey, a beer sure kind of helps me cope with that, at least in the short term. But then what happens is this, like, oh, I'm stressed again tomorrow, or I'm depressed, or had a fight with, and then I got to drink again. And then that's reinforcing pleasure and pain principle, right? Like it feels good and it gets rid of the pain or the emotional distress. And so then I've got to do that more and more, builds up distress, builds up dependence and tolerance and all this. It's not necessarily the exact same with a compulsion, but it's a similar principle in that in the short term, it alleviates that distress or that anxiety. But then what happens is, that sense of relief, that sense of certainty I've given myself. Then I've got to do that again the next time that thought comes up or a certain situation arises. And you're right, then it's a cycle, and it's tough to break, but that's kind of what we need to do when we're helping someone.
Yeah.
To help them understand the cause and effect and then kind of reverse that.
Yeah. And I picture the tolerancer being able to sit with the uncertainty, right? Like that goes down then during this whole process.
For sure. Yeah. Because I mean, what you're simply essentially doing is sort of eroding your ability by experience, eroding our ability to tolerate that uncertainty by avoiding it, by doing certain things that sort of put us at ease, by seeking reassurance. And then we're teaching ourselves, I will be okay as long as I don't do that thing and ask for this person for, okay, I'm okay, or I'll double check something on the internet. Okay, at least for now, until I question it or have to do it again. And then even though we think we have control, we've essentially lost control because this OCD pattern is taking up more and more space.
Yeah.
You know?
I heard, you can correct me if I'm wrong on this, that like OCD goes after things you care about in a way.
That is often the case. Yeah. And I say often, just because, no two cases are the same. But you could phrase it this way. There are sort of some main themes that tend to be tapped with OCD related thoughts and behaviors, generally related to control in some form or fashion, uncertainty, as we said, or safety, right? So am I a safe person? Am I a safe mother if I had this thought that I could harm my baby? Maybe I'm actually not. I'm fooling myself. Right. Okay, so I'm a newly minted mother. What's more precious to me and on my mind than this precious thing that I'm, that's dependent on me? Another common form of OCD is there's sexual orientation. So sometimes people say, I noticed, let's say I'm a cisgendered heterosexual male, and I see another male, and I say, oh, that's a good-looking guy, and then I think, why would I even have that thought? Was it? And then sometimes that thought can cycle into OCD, and then sort of prey upon a certain way that I've internalized a sort of masculine or heterosexual identity that, maybe for someone else, like, no, I'm not worried about, I know that I'm straight, or I know that I'm gay. I've never questioned that really, or at least not for a long time. And certainly not in an OCD realm, but I'm just so worried about someone breaking into my house. I watched a documentary on the Night Stalker, and since then I've got to check the locks 17 times every night. Or someone burned their house down, I've got to check my stove every time to make sure. But yeah, I'm not worried about this other thing. And so now for other people, it kind of can jump around. Some people will say, boy, when I was in my teens, I really worried about someone coming in the house. And then there was a period where I worried about my sexual orientation. Other people, and then when I grew up, and then I got my driver's license, then I had this constant fear that I had run over someone in my car. And just to be safe, I would circle around the block to make sure there was no, you know what, I didn't see clearly though, because I had to pay attention. Let me circle again just to be sure, right? And then it's compulsive and can really, grow its own teeth,
It's so interesting, especially as you describe the car driving one, where it's like, there's that concern or that thought like, oh no, did I, right? Like, did I run over someone? So I'm going to go check. Sounds like someone who is super caring and probably wouldn't even want to do that. Really?
Right. Yes. Well, and this is where it gets interesting because, let's say we have someone who says, I had this thought about jumping off a bridge. How do we know that that's OCD and not a actual credible threat that someone could actually harm themselves, right? It's because the person with OCD, that image causes distress for them because they don't actually want to do it. The sort of fancy psychobabble term is it, ego syntonic versus ego dystonic, which basically is like, no, if someone is depressed and they have a lot of risk factors for depression or self-harm, or if they've done it in the past in some other form or fashion, they're thinking about it. It's going to be a different kind of conversation in therapy that it's like, I've had a thought. I don't think I'll do it, but I might. Sometimes it'd be easier if I wasn't here, or sometimes it just feels too overwhelming, or, it's different from like, oh my gosh, like I now I can't go to bridges anymore because like I would never do that. Like I'm not depressed. I don't want to end my life. I would never do anything like that to my family. But I just had this image of what if I just did it? What if I had an impulse to do it? And now I just can't get that thought out of my mind. If there's an effort to push it away, avoid it, explain it, check that I won't do it or that it won't happen, it feels very different. And that's how we can sort of decipher the difference.
Yeah, that makes sense. Thanks for explaining that. And I think that's one too, that like, I think that's the harm OCD, right? That it's so interesting, like how there's so many different types of subtypes, including that. But I'm glad you made the distinction, because it's like, yeah, how do I know, or how does someone else know, like if this is like, like intentional, like SI, or like just having the thought and they're so worried about it, they're actually trying to call it pulling away from many things so that they don't go anywhere near some sort of harm, because that's like their concern, right?
Sure. Which is avoiding, right?
Yeah.
And it's never really testing. If we just avoid something, we can never really test whether that thing will actually happen. But it's very, seductive to want to do that, because the more I avoid it, that's the only way I feel okay. And now you mentioned harm OCD, right? I mean, that the example of jumping off the bridge, that's an act of self-harm. But as I mentioned, it could be an act of, unwanted thought of harming someone else, a baby, as I said. You'd imagine some people who said, I just had this, I watched this thing in the news of a horrible school shooting, and I just had this thought of like, well, what if I did that? Yeah. And it's, oh my gosh, why would I even think that? Am I capable of that? And my concern is always, what if someone like this, dealing with those thoughts, came to a professional that didn't know what they were doing with OCD and didn't really understand the difference, and they would say, oh, this could be a credible threat. Let me, call the third party or get law enforcement involved. And they may not understand the nuances of OCD. And then pretty soon this person may be involuntarily hospitalized or, medicated or treated in ways that may or may not be helpful for them, or may actually be harmful or traumatic to them. So that's always a concern. And that's why it's so important to understand the nuances of it. And, it's just not everyone's specialty, unfortunately. So it can be tricky.
Yeah. What does treatment look like for OCD?
Well, so the gold standard treatment for OCD is something called ERP, or exposure with response prevention. By the way, a great resource is the International OCD Foundation, or IOCDF. And on both the IOCDF website, our website, cbtsocal.com, there's a lot of information about exposure with response prevention. But essentially, I explain it like this: is exposure basically means confronting things that cause distress, thoughts, images that cause anxiety, which are the obsessions. And response prevention, the RP and ERP, basically references cutting back compulsions. So if I'm someone who has a lot of anxiety about germs and getting sick, well, I'm probably going to be very careful what I touch. Maybe I stop touching, or I use, my elbow to handles, or, paper towels to touch every handle, even if it's in my own house, and it just builds it more. And so I'm avoiding that. But I'm also doing some compulsions or rituals with washing, after I, handled some dirty dishes, I will wash up past my elbows, or I will wash so many lathers of soap to the point of have my hands being dry and cracked and bleeding. And so the exposure basically means we've got to start systematically and hierarchically touching, having manual contact with some things that we may have been avoiding. And the response prevention means we've got to cut back the washing. So we're sort of hitting it from both ends, and you really have to do both with OCD if both are big features there. And the other thing I should just say to your question, Robin, is just, sometimes people they hear that and like, oh, that feels so difficult. This is really uncomfortable. And you're right, it is uncomfortable, because we're reversing the flow of a pattern that's built up and asking people to do some things that are uncomfortable. But I always sort of say is, we don't just throw someone into the deep end of the pool if they don't know how to swim, right? We scaffold, we give information, we give coping skills, we give a rationale for why we're doing this. And then we start with some discomfort, but something that we agree upon is a tolerable amount of discomfort, just to step by step stretch the comfort zone and then build up from there. If someone's afraid of heights, we don't go straight to the top of a skyscraper downtown. We've got to go to a second floor balcony. I was sort of this example I use, and maybe confront that and realize that is tolerable, and then move up from there, and so on and so forth. So it's the same thing with exposure with response prevention. Yeah.
It's like a ladder, kind of going up the ladder to what's
and
going down in avoidance, sounds like, as well. Decreasing
same thing. Yeah, right. Mm-hmm. Sure. So that's a very brief introduction to what ERP for OCD can look like. Obviously, it may not always be that clean or simple in practice, because people may be dealing with more than one mental health issue. There may be other health concerns, other stressors, multiple forms of OCD, but generally that's the framework.
Yeah, that's really, really interesting. But like you said, helpful, because if not, it'll just things are feeding into that avoidance, right? Or the compulsions,
Yeah.
but it sounds like it's done in a way where it's like collaborative, it's safe ultimately, and it's gradual. It's not like diving right into something.
Yeah, I mean, absolutely. It just wouldn't be effective if we said, oh, you've been afraid of heights, like let's, book a flight to New York. Like it's just not going to happen. We have to work up to it before someone is willing to take that risk. And that's okay. I mean, that's what we're challenging our clients, but we're also encouraging, and we're validating kind of the distress of the cycle they've been stuck in, all of that, and then building a rationale and a case for trying something different. Because if they're really suffering from OCD and they've found their way to us, what they've been doing hasn't been working, So,
yeah, definitely.
Mm-hmm.
Could you describe CBT as well? Because I know you brought up ERP, which is good, and like maybe how that's what CBT looks like what it is or why that's like unique, I guess.
Yeah, I would say that exposure with response prevention, or ERP, is sort of under the umbrella of approaches of a larger umbrella called cognitive behavior therapy, or CBT. Long story short, I mean, the general approach with CBT, or the general idea with cognitive behavior therapy, is that a lot of emotional distress is caused by or an expression of some sort of learned behavior through our lifetime. And that may not necessarily be, early childhood adverse experiences. It could be. It could be that in addition to, or maybe more just things learned later on in life. But symptoms of anxiety, OCD, they kind of, as we sort of said, to develop their own cycle, their own symptoms, their own form. And if these sort of disorders or mental health challenges are learned and reinforced through some pattern of behavior, that means they can also be unlearned. And that's what we try to do with CBT, where the emphasis is not so much just on sort of general talk therapy. I mean, obviously there's an element of that. We talk with our clients and really need to understand them and get the information we need to get a working conceptualization. But it's not just sort of with a focus on past experiences and childhood and early caregivers for its own sake. It's so that we can develop a roadmap of what to do, what can we do proactively, concretely now, and not just what happens in session, where we may have insights and aha moments in session, but we also want to give people things to be working on in between meetings so that they can be proactively working towards their goals. And with a lot of anxiety issues, with insomnia, with OCD, you really kind of have to do that to keep things going, rather than just relying on what happens in between us in the sessions. We do some work there too, of course, but we give people things to work on in between meetings. Sometimes we call it homework or exercises or applications. So we're a little bit more hands-on and concrete with that. And in general, also, we're a little bit more sort of tangible with kind of how we're trying to understand the situation and direct it from there. Yeah. So that's, again, a very general, brief, broad brushstrokes of CBT. Some people will talk about CBT as focused on cognitive therapy, which is just changing people's thoughts. For us, I mean, there's an element of helping people examine their thoughts and whether they're helpful or working or make sense or not. But it's really also driven by behavior, the B in CBT. What can we do that tests our old assumptions, or that changes, or that could lead to a different outcome than maybe a pattern that we're stuck in? And that can change our thoughts from there, if you will, or our basic assumptions about ourselves, our self-esteem, our beliefs about other people and about the world.
Yeah, so that makes sense. I'm glad you described it that way. And I like how because you're correct. When I've heard others like kind of describe the CBT, it's so much on like the C, but not so much the B, totally. Which is the other crucial piece, and highly important. And, it's interesting because we have lots of thoughts and feelings. Hard to control them sometimes. Sometimes they actually make sense while we're having these thoughts or feelings, but what you do have control over, or even what can work with, is like the behaviors or how you respond to the thoughts and feelings that show up for you, right?
Sure. Yeah. No, and a lot of people are really, and rightly so, have an adverse reaction to the idea of just someone telling them that their thoughts are rational. It's like, yeah, I know that's the whole point. That's why I'm here. I don't need someone else to tell me that. Or some people feel they've been really traumatized by, dare we say, sort of maybe ineffective or poorly done CBT, where someone said they were doing CBT and basically, here's how you're thinking, and that's not working. So let's think a different way. And a lot of people say, yeah, I know that. That's not the issue. And so if we can kind of speak to some of that, but really get to, well, what can we do that's different? The behavior, especially when it comes to something like OCD, but even, depression or whatever we often find we have more success and more traction focusing on changing habits, making different choices, communicating differently, confronting fears rather than avoiding them. That's behavior. And when we experience something different as a result of doing something different, that changes our thoughts. That it's sort of I don't want to say back end way of changing cognition or thinking patterns. So it's both and, but it's just a different mechanism from some of the simplistic ways that CBT is often portrayed and maybe even practiced.
Yeah. And that also sounds, empowering in a way too. Like, it's like, so I'm doing these different responses or different habits and behaviors. And through that, it's doing something with my thoughts. Maybe it's altering things. But I think too, for someone to experience difficult thoughts and feelings and move and behave in a certain way, even though they're experiencing that and they got through it.
Right.
Like, I think that's super empowering and healing. Like, you got through that distress. That was really hard and tough for you. And you did it.
You bet. Yeah. What's more empowering than that?
Yeah.
Right. And the challenge is, like I said, understanding the situation up and making the case for the person we're working with to test that, because that's going to be scary. It's going to be uncomfortable. That's why we have to set up the conditions where maybe they're not risking so much, or maybe it's like, no, that's within reason. I think I could do that. It'd be uncomfortable just because I'm in the habit of avoiding, but I think I could do this. I think I could go this far from home or drive this far or whatever it is without checking, and then build up from there. But experience is the best teacher. And they say it, this is why we people who are musicians or artists or athletes or performers, that's why you rehearse, right? And that's why people who are experienced at their craft, who have, played at high stakes level athletics, then, can repeat that because they've been in that situation before. They can play under pressure. They can perform in front of a big audience, right? And at some point, new people have to develop that experience, but, you can't just teach that. Right. So similar thing is we can teach, we do to a certain extent, give people guidelines and principles and help them make sense of what they're dealing with. But in the end, the real power comes from testing it and from doing something different and experiencing something different. So.
Yeah, it sounds very action oriented, and also all the more reason why, like, because as therapists, right, we see people for like 50 minutes once a week usually. That's like a very small amount of time, as opposed to like, the time in between sessions,
Right.
So that's kind of where that practice comes into play and testing things out. Like, I feel like that's where a lot of the stuff is too, is like how it went, when you're practicing it on the outside or more frequently. Because and I feel like it's kind of different in session, too, when we're with our clients, and they may also experience something different as opposed to when they're trying it out on their own outside.
For sure.
Yeah.
Right. And it, obviously it depends what we're talking about, but, we've had people, let's say it was OCD and someone didn't want to touch the doorknob of the office and they see me do it. And I didn't run to the bathroom to wash my hands. And I even, whatever, touched my glasses and touched my clothes. And now whatever it's on there, I've spread, and they're like, oh, no, I'm just seeing you do that and you're okay. And then maybe that makes them more willing to do it in session with me. But it doesn't end there. Can we carry that over into the real environment? So, therapy is a sort of constructed space and relationship, and it's very powerful. It's a laboratory where we can talk about things and test things, experience new things too. But as you said, the real world is not in a therapist's office. Ultimately, what matters is the changes that we're helping someone accomplish. Do they translate into the real world in a tangible way? And so we've had people who sort of say, I worked with a therapist who was great, very supportive for a long time, but I didn't feel like I was getting better. They just said, I wanted concrete skills or recommendations. And the recommendation I got was just more therapy, just keep coming to therapy. And I said, I get that. But I also understand from a client's perspective, sometimes you want to be given some tools or some direction. If when I had, if I have a back injury, I want the chiropractor or the physical therapist to say, do these stretches, do these exercises, and that will alleviate the pain. Ah, thank you. I mean, it's a simplistic analogy because not everything in therapy, psychotherapy is the same, but to some extent, sometimes you just want someone to say, I know what this is. Yeah, right here, this vertebrae, do this, and that will help. Ah, thank you. What a sigh of relief. And so we really try to do that as much as we can with CBT.
Yeah.
So, yeah.
And as you described when you gave the example of the doorknob and like how they see you touching, I almost feel like, and this probably vary like OCD subtype to subtype or, case by case, but like the therapist also level of comfort. And also like, if we're going to ask clients to do stuff or maybe take certain steps, like not, whether or not we do those things, like our own feelings and thoughts about that, because if we're asking them to do something, right? Does that kind of make sense?
Sure. Yeah. And this is where there's a level of creativity and sort of organic, variability in what happens between the therapist and the client. There's another common anxiety disorder that often overlaps with OCD called emetophobia, which is a fear of vomiting. And it could be seeing someone else vomit or vomiting oneself, or even just hearing or picturing, all that. And there's a debate out there in the specialist communities about whether the end goal of treatment needs to be to actually have someone purposely induce vomiting. And most people agree that you don't have to, that's not necessary to really bring about meaningful change. It's more about tolerating the uncertainty and some of the possibility of certain conditions around, the potential to get sick. But I've met people in the field with similar specialties who they will actually get to a point with their clients where they will take Ipecac together in session, where they'll have a garbage can and the client will have a garbage can, and they'll both say, okay, 1, 2, 3, we're going to take the Ipecac, and we both do that together. I've not done that in session, but I know I've had, other professionals I've met who do that. And so, case in point in terms of like, what is a professional willing and able to do, and whether you think that's helpful or not, too. So, yeah.
Very creative, very interesting. Yeah, I think I'm more in the stance of like, kind of like it may happen or it may not, and sitting with the possibility of either way.
Right.
Yeah.
And that's the argument for like, okay, maybe we don't actually have to have them do it, let alone do it with them.
Yeah.
But we have to maybe face other ways. Like some people with emetophobia, it's like they can't even say the word vomit, barf, puke. They can't write the word. They can't see the word. They can't look at a cartoon image online of, somebody looking like they might, hurl or something, right? And we have to kind of build up some of those as like, well, could that be tolerable? And like we sort of said, step by step, take back more real estate and proactively test their ability to tolerate that discomfort.
Yeah.
So, yeah.
Is there, I know I asked a lot of questions. So is there anything I didn't ask about that you would like the listeners or viewers to know, or something you want to share? Anything else?
Yeah, I mean, I that's why we're here to answer questions and hopefully give information. I mean, I guess the other thing we see a good amount of is insomnia, and it's some people don't know that you can actually do things in talk therapy, if you will, for insomnia. They think, oh, you take Ambien or Linest or whatever, because there's so much billions of dollars going into promoting those drugs. But most people would probably say, if I didn't have to take a medication, to do something that a newborn, baby is capable of doing for 18 hours a day, then I'd rather not. But behaviorally, the frontline treatment for insomnia is CBT for insomnia, where we don't just address sleep hygiene, we address associations with the bed and the bedroom. We talk about sleep scheduling, and just I've really come to think of insomnia as an anxiety disorder that just is focused on sleep, and so that's something that a lot of people on our team do some work with. So just kind of a unique thing to put out there and just share in case that's obviously not, intuitively not uncommon for people to maybe dealing with insomnia in addition to some other form of anxiety. So that's something we work a lot with. So yeah, and other things sort of adjacent to what we do is, some working with some people who have tics through what we call comprehensive behavioral intervention for tics and Tourette's, habit reversal training for people who have body-focused repetitive behaviors. So people pull their hair, trichotillomania, or pick their skin, which we call excoriation disorder. These are sort of the more kind of other specialized things that sometimes make our way into the people that we're helping with.
Thanks for mentioning those, because I think not everyone may know that there's like specific treatments for each of these things, actually, and they may be experiencing, right, or just thinking like, I'm glad you also earlier talked about the distinction from like, typical like talk therapy, because these other ones, the interventions are quite different, and how it's being implemented or what's being implemented, because I think sometimes, I don't know, I guess I shouldn't generalize also like what people, may think when it comes to therapy, but I think there is that general, like, we just do talk therapy, when there's so many different types of interventions out there for so many different types of, difficulties that are actually really targeted, and that it can actually make so much more of a difference. So it's good for people to know, that you're not just going to sit there and just talk about things in general. It's very much active, and it sounds like the therapists, that work with these are also active themselves, and also maybe even a little more solution focused in a way, and like, so that, these things can be, better managed than what they're currently experiencing.
That's what we strive to do. I mean, obviously there are people who we work with who there are times when someone just needs support, or they just need to vent, or there's a lot of history we do need to get to really develop a helpful conceptualization of what to do. And that's okay. We can do that too. But I mean, at the end of the day, our job is to be helpful and to, work someone out of our office. And if without sort of some tools and some, roadmaps to do that, it's a lot harder to do that if it's just kind of more non-directive and open-ended. So, yeah.
Definitely.
Yeah.
Well, before we end, could you maybe give the listeners or viewers like website or social media handles where if they want to find out more about you or CBT SoCal?
Right. So, I mean, in long form, our practice is called the Cognitive Behavior Therapy Center of Southern California, but our website is cbtsocal.com, as well as our, we're not too active on social media, but we have an Instagram page, CBT SoCal, Twitter and Facebook. But really a lot of our main content runs through our website. We have blog contents on OCD. I have a colleague, Dr. Von Steets, who's a sport and performance psychologist. So he writes articles about that. We have people on our team who work with kids and teens a lot. I don't myself a ton, but so we have a number of different specialties and sort of clinical focuses, foci, I believe. Yeah. So yeah, and if people have other questions, we have got a contact form on our site if we can be of help. And obviously we, a lot of people come through our site, and if for whatever reason, if we're not the best fit, it's helpful to know other people with different specialties, like yourself included, to sometimes how it is, as someone comes to you and you're like, I don't really work with OCD or something, but I know who does. And bipolar disorder, it's not something we work a ton with, so but I know someone who does. So it's just helpful to have other resources and know other professionals. So we really try to all be a team that way.
Definitely. And since we are still in the world of the pandemic, so CBT SoCal is it up to the client whether they do video or in person, or what does it kind of look like for now as far as the way it's implemented? As
of now, we're still primarily operating remotely just to be safe. I don't know when this will be published and who will be watching this whenever, but we're sort of in the period of COVID where the Omicron variant is kind of on the surge, and we're going into the holidays. So, we want our team to, to feel safe. We have a couple of people on our team who have done very limited sessions in person, case by case. If it was, someone that just couldn't benefit from being seen online, if it was a kid or something. But for the most part, we've stayed online. We have 2 offices though, one in Glendale, California near Pasadena, and the other one in Torrance, in the South Bay. And so, for future reference, that's where our 2 teams operate from, even if remote. And my guess is even after things, hopefully resume some sense of normalcy and the pandemic, improves, is that, there will always be some people who probably will access us remotely, and probably the same for you. And so we'll always offer that option, would be my expectation at this point. So, yeah.
So that's good for the listeners and the viewers too, especially with the diagnoses that, CBT SoCal works with. I know they are very much like, specialized. They're very specific. So that's good, because then, and for the listeners and viewers, if you don't know, when we're licensed, at least I'm LMFT, but when we're licensed in our state, we could see clients who reside anywhere in that state. So that means that, like, say you live in like NorCal, or maybe, San Fran Bay Area, and you want to go, receive services through CBT SoCal via video, that's something you can do, as long as you are a resident of California and you're living here and you are in the state when you sign on to that video as well. No vacay, but you've got to be here. So I think in that sense, if maybe that was like the one thing with this pandemic, is it really opened up our reach when it comes to clientele, especially when it's something that is very niched and specific, such as like OCD, insomnia, the body focus, repetitive behaviors, all those, it's very important to have a therapist that is knowledgeable and experienced with those treatments. So what I'll do?
I mean, it's strange.
Oh, go ahead.
I mean, we people who are living in remote areas of the state. I mean, it's not that telehealth wasn't available before. It's just that nobody was in such a frame of mind that telehealth was the only option, and now it's sort of like, it's not this foreign thing anymore. It's just the norm. So, anyways. Yeah.
We're all 2 years in, or almost 2 years in. I think we're all kind of gotten more used to the video thing. But you're right. Yeah, before it was kind of like, I know I did it a little bit before the pandemic, so it wasn't too much of a transition for me. But I feel like now, I think some people even prefer it too, really. And especially if you live in a remote area or certain areas, it's a lot of traffic sometimes and having to drive. So sometimes it's actually more convenient anyway.
Yeah, for sure.
Yeah. So what I'll do too is I'll put the your website and then also the social media handle in the show notes and on the description on the YouTube version of the video. That way the listeners or viewers, they can just easily click on it if they want to reach out for any questions or services or anything. So thank you again, Martin, for doing this. It was a pleasure having you on. It was so helpful and informative too.
My pleasure. Hope this information is of help to someone.
Yeah, I think definitely is. All right. Well, take care.
My pleasure. Take care.